Okay, welcome. So thank you very much. My name's Ivan Wong. Welcome to our second Sports Medicine Journal Club of 2021. Thanks so much for joining us virtually tonight and hope you enjoy. I just want to take a moment to thank our guests and members of our sports team here, to sports and research team for joining this this evening and making this event possible. So topic of today is management of massive cuff tears. Our journal club will begin with a case presentation, followed by presentation by two of our fellows on two relevant articles and various discussions. So those of you who are online, please use the chat function on YouTube. We'll bring it up on screen and do our best to answer them and have a discussion about those things. Hopefully this generates lots of interest because I know this is a very difficult topic to deal with. I'm very happy to have both our co-mentors in our fellowship, Dr. Kathy Cody and Dr. Nathan Urquhart, here to contribute to this evening's discussion. So we're going to start off this evening by introducing our guest moderator, Dr. Andrew Trenholm. So Dr. Trenholm has completed his undergrad degree, medical degree, and orthopedic surgery residency at Halifax Dalhousie University. He pursued a subspecialty training in orthopedic trauma surgery at the Carolinas Medical Center in Charlotte, North Carolina, USA. After completing his trauma training, he moved to Edinburgh, Scotland, to pursue a subspecialty training in upper limb surgery and sports arthroscopy and arthroplasty. He began his medical career at St. John Regional Hospital in 2003 and transitioned to full-time academic practice in Halifax in 2012. In 2013, he completed his master's degree in clinical research administration at the University of Liverpool. He's currently an associate professor of surgery and chair of Orthopedic Trauma Association Research Grant Committee, co-director for Dalhousie University Upper Limb Fellowship and Surgical Foundations Program, and the unit head of the MSK Durham Med2 block, and sits on Nova Scotia Health Authority's Research and Ethics Board. So thank you, Dr. Trenholm, for joining us today with his fellows of upper extremity. So tonight, again, we'll go through two different fellow case presentations and then go through the articles with that. I'd like to have our colleague here, Dr. Kathy Cody, introduce our first fellow.
Okay, so it's my great pleasure to introduce Dr. Jose Casillo. He was born in Mexico City and raised in Querétaro. He attended medical school at Querétaro Autonomous University and then completed his residency at Mexico National Autonomous University in Mexico City. He's currently completing his sport medicine, arthroscopy, and joint preservation fellowship in Halifax at Dalhousie University. Take it away.
Perfect. So thank you everyone for broadcasting. So as Dr. Wong said, we're talking about massive repairable rotator cuff tears. We're going to begin with a presentation of a case that we had. So nothing to disclose for this case. So this is our 46-year-old patient. She's a female, she's right-hand dominant, she's a paramedic, so a lot of physical work. The presentation, so she began a couple of years ago with some shoulder complaints, pain. She didn't have a precise injury or trauma. She began with progressive pain and decreased range of motion. On the physical exam, she had a flexion of 145 degrees, abduction of 140, positive jaw and Hawking signs, as well as external rotation weakness. So just with the physical exam and the story, we can suppose that she has a posterior superior cuff tear. To get further diagnosis, we did imaging. We got x-rays. Here we have her x-rays. We can see some humeral head superior migration. We can see some acetabolization of the acromion. So it could be categorized as a Hamada between 2 and 3. This is the Hamada classification, so this is important. We'll talk about it later. And this is the arthrogram we have of this patient. So we can see that she has an intact subscap. It's perfectly well inserted, has good tension. Here we see that the head is almost bare. There's no tendon on top, so supra and infra both are torn and are retracted to the level of the glenoid. Another view that we can see, there's nothing on top of the head, just the biceps remaining. And well, the fat infiltration, this is not like the best slide on the MRI to assess the fat infiltration or the muscle atrophy, But this is an old study, and this is how far medial we can go. So this is the best cut we had. And we can see that there's a lot of fatty infiltration in both the supraspinatus and the infraspinatus. Teres minor and subscap look really good. So with everything we have so far, we can see it's a functionally irreparable rotator cuff tear with a Hamada rotator cuff arthropathy between 2 and 3, mostly like kind of a 3. Patellar retraction stage 3, that means that the tendons are retracted to the level of the glenoid. There's an example of the patellar classification, and a good old ear index of both the supra and infraspinatus of 3. The infraspinatus can be kind of a 2, but both of them have a lot of fatty infiltration. So this is the first surgery that was performed for this patient. It was a bridging reconstruction. This is an arthroscopic advanced technique that's performed. Maud is going to talk about more of the details of that technique later, but it's basically covering the defect of the rotator cuff on top with an allograft. This is a scheme of what's done. This is a diagnostic scope of the third surgery, so we can see some cartilage changes already going on. We have the biceps, nothing on top, a little bit of the teres minor remaining, and we can see that in the front of the shoulder the subscap is intact, so very well inserted, good tension. And this is the final view of the first surgery. So this is the allograft on top, covering all the defect, all the sutures around, with a double roll fixed to the GT, so a very stable fixation. But even though the surgery went well, the patient didn't do very well afterwards. So in the follow-up, she began with some pain, worsening external rotation limitation. We can see that the patient-related outcomes, the work index before surgery was 66. It improved to 39 at 1 year, but it decreased again to 56 at 2 years. So in the follow-up examination, we can see that this is the patient with a very good flexion, but you can see that there's a lag on the external rotation. Just ignore the other arm because she also has trouble in the other arm. Just focus on the shoulder that has a trouble. She has no trouble with internal rotation, and when testing the strength of the external rotations, she was quite weak. So very good flexion, very good internal rotation, but a lot of lack in the external rotation. And we can see the progression of the imaging. So the first image on the left is the first x-ray she had before the first surgery. The x-ray on the middle is the x-ray that we got 1 month after the surgery was performed. We can see that the humeral head migration was a little bit better, and then it progressed again with superior migration and a year and a half after the first surgery. So we got a new arthrogram. We can see also that subscap is preserved. It looks good. And we can see that there's nothing on top of the head again. There we can't see the graft anymore, so the cuff was not changed, it's still retracted. And now we have hardware on the head. Same thing as we saw last time, so just the biceps on top, a little bit of cystic changes on the acromion. And the fatty infiltration kind of progressed, so both supra and infra, teres minor is the same, subscapularis looks well. So now we're facing a failed bridging reconstruction, the same classification for the rotator cuff arthropathy, same girdle fatty atrophy, and well, the same retraction. So Dr. Al-Hassam defined a functionally repairable rotator cuff tear in 3 major things. One was the retraction, so if the tendons were retracted to the glenoid, so a PATET 3. He measures on the coronal cuts like the tendon length. If it's less than 10 or 15 millimeters, it's also one of the criteria for an irreparable rotator cuff tear. And also the fatty infiltration, so more than 2, that's more likely for a tendon not to heal. And well, he doesn't mention the the arthropathy with the Hamada classification, but I think that soon this is going to be added to the Repairable rotator cuff tear because it's very important. Even though any technique is used for fixing the rotator cuff, all the patients with above 2 of a Hamada to arthropathy, they don't do really good. So treatment options, we have a lot of options to treat this patient. We have to take in mind it's very young, he's 47, he's active. So partial repair, I think it's not on our list. Bridging reconstruction was already performed, it failed. I don't know if it's the best option. SCR, it's almost the same. So it's not ideal for this patient. Supracranial balloon, there's not a lot of evidence to use it. Tendon transfers, they have shown to work well, both lat dorsi and lower trap. There's evidence supporting both of those procedures. The patient is not as bad to just perform a CAM procedure as described in Bale, or a reverse shoulder arthroplasty. So she is very young to go to the arthroplasty. Maybe she can go for that afterwards, but not at this time. So there's a lot of evidence supporting all of the procedures. So the gurus of all of the procedures have their papers. So Burkhardt with the superior capsular reconstruction, Mihara as well, superior capsular reconstruction. And there's some evidence regarding the supracranial balloon. The bridging reconstruction, this is the paper that Maud's going to take care afterwards. It's important to say that there's very few level 1 studies. This is one of them. The balloon, the lat dorsi with Dr. Gerber, the lower trapezius. This is the first study that was published by Dr. Al-Hassan, which is with an open technique. And well, the reverse shoulder, we know that it works, but only in older population. Well, it works in older population, but it's not long lasting. So this is what we did for the patient on the second surgery. This is with the revision surgery. So this is basically what we do. So it's an arthroscopically assisted lower trapezius transfer. So what we do is harvest the lower trapezius from the posterior aspect of the scapula, and then we connect that to the GT with an Achilles allograft. So the technique was described in a V-shaped position, but we usually operate on lateral decubitus, so we perform the surgery in lateral decubitus position. It's important that once you outline the landmarks on the skin, don't move the arm because the landmarks would change. So it's very important for the harvesting of the tendon not to move the arm after doing the landmark outline. The first thing to do is to harvest the lower trap. So we can see that the lower trapezius is a very huge muscle, and we're only harvesting the lower portion of it, which inserts in the medial aspect of the scapular spine. So we do an incision, we identify the tendon, and we harvest it. This is the pictures that Dr. Al-Hassan uses in his article. As you can see, it's described in a V-shaped position. We did it in lateral decubitus position. And this is how we harvested the tendon. So we identify it and then we detach it from the scapular spine. It's important to take care that the spinal accessory nerve that gives the innervation to this nerve runs 1 centimeter medial to the medial border of the scapula underneath this muscle belly. So it's one of the important landmarks to have in mind. After harvesting the tendon, we whip stitch it. And this is the excursion that we have with that tendon, so it's pretty good. On the back table, we prepare the graft. It's important to use 2 different colors for the sutures. We use one that's going to be on the medial row, that one's going to be on the lateral row. And also it's useful to use some ink and color one of the sides of the tendon so you know what's on top and what's on the bottom. We can see it afterwards in the arthroscopy. This is the scope of the revision surgery. This is the posterior anchor where we can see that some of the cuff that was repaired at that time worked, But then if we can look at the top part, there's no graft left. So just the biceps in front and subscapularis, that's also correct, but there's no graft left. We took a couple of samples for culture. Even though there were no signs of infection, we know that C. agnes is a low-grade infection that doesn't give a lot of symptoms, but the cultures came positive for C. agnes, so the patient is now under IV antibiotics. We debrided the GT, took as much of the hardware as we can. Then we used a burr. And then we used the coplator to create a plane on top of the infraspinatus, so we can connect the incision we did on the skin with this scope part. And then we pull the sutures through, and this is the tendon going on the shoulder. So as you see, there's some ink in this side. Now we know that's the top part, and the bottom part it's underneath, so that's correctly placed. And here you can see on the image on the inferior right corner how we fix the graft. So we only use 2 knotless anchors. This is the first one that acts like a medial row, so just next to the biceps anchor. And then we use a lateral one to fix the other aspect of the tendon. After it's fixed, we go outside again, and then we put the arm in abduction and external rotation. Then we put the Achilles tendon through the lower trap. And once it's through, then we fix it on its own. Make a secure fixation with non-absorbable sutures. And this is the final view on the shoulder. We can see that the cuff, well, there's a hole in the cuff. It's recommended to make at least a partial repair if it's feasible. If not, you just don't do it, like this case. But we have now the Achilles tendon on the posterior superior aspect of the shoulder. So now we can do the discussion about the case. I don't know if you have any questions, comments. So there's some healing. There's also failure reported at this site. So this is the paper I'm going to talk about it. And they report, I think, I don't remember if it's 2 or 3 graft failures. They don't describe it's actually the graft failing on its own or the junction between the graft and the body tissue. But I think there's some healing because it's worked. So they present a lot of patients with good outcomes, and they don't report that that's part of the big issue.
And how can you enhance the healing at that interface?
I don't know if adding biologics would change. Maybe that could be tested a couple of years after if we can see that that's a big of an issue. But so far, that's not been shown to be like terrible. So yeah, maybe that makes sense.
And one other question: how do you know how to tension it? Like, how do you know what?
Yeah, that's
like what's your tension on that?
There's not like a precise measurement. Yeah. So Dr. El Hassan describes first the position. So the arm is going to be in abduction, external rotation. So it has to be tight there, but not super tight because the arm is going to go back again. So it's a feeling thing. So it's not super tight, but not super loose. So it's something in the middle. So you have to have some tension, but not over tension.
Okay, and so then are you you're repairing it on the humeral side first, and then doing the tensioning on? Yeah. Okay.
Very interesting. All these tendon transfers, right? How do you gauge tension on tendon transfers? And I think plastics has the same thing. They got to figure out what it is, so they put everything on the maximum stretch or maximum tightness they can. They kind of tie it there, and that's kind of the best you got. And it's over time you figure out what you got, right? So some of the principles of tendon transfers, you need whatever excursion, the same amount of excursion the normal tendon would have. That's where I think his Bassam really showed that the lower trap does have excellent excursion, when we're doing it, really, you put on maximum stretch, so as tight as you can possibly could. You tie it as tight as you can. Try not to let them pull it apart, and hopefully that's enough tension for that patient. It's really tough. I think we really need to design devices to be able to measure that for everything that we do.
So like, are you weaving it, or like, is it non-absorbable
It's a weave.
sutures, or are they just? So,
And non-absorbable.
but are you like putting it through and back onto itself, or? Yeah.
So do you have a picture of that? So actually what we do is that lower trap, you actually tie at the end.
Okay.
Puncture through it. So you
Yeah.
take your Achilles allograft, it goes through the tendon in the lower trap that's reinforced with suture, and you tie it back on the Achilles itself.
Okay.
And then you whip stitch the whole thing together, so you know minimum chance for it to. It's like a pulver taff weave, right? So it is actually a really nice construct, assuming it doesn't tear through, assuming that it heals, because obviously the tendon in the lower trap is pretty flimsy.
Yeah.
But it has have nice excursion of that muscle belly. Like, so if it works, it's really interesting. The weird thing is you leave this massive hole still where supraspinatus is, right? It really does a good job of replacing infra. It does a horrible job of replacing supra. So that's where the question comes, is what do you do about supra? And you're supposed to repair it if you can, but
Yeah, there's no
nothing
tissue
to
here
repair.
to repair.
Funny, some of the times when I have like these ones where you're tying allograft into like a tendon, especially with a short stump, a lot of times I'll use like a dermal patch over top of that to give it a bit more collagen, and then when you're throwing your sutures through it, it almost creates like a sandwich and shares the load a little bit better. So it's something like, using in other parts of the body, is a little trick. And I think actually, we always worry about not enough tension, but I think that a lot of times we probably over tension these repairs more than we under tension them. I think I probably do.
No question. There's a few papers actually just came out talking about tension, right? So Journal of Arthroscopy just came out with one. I can't remember which group. I think a Korean group is coming out. Again, now trying to identify what's the right tension. And I don't know if we'll find that answer, but I think we need to start measuring. I think most of our instruments, we need to start measuring how much tension we're putting in all of our constructs. And then try and figure out what that number should be to minimize the re-tears, because I think we're not recognizing the re-tears. Even though they don't match clinically, we're now getting the data to show that longer term, if you follow them 2-3 years out after they've retorn, they don't do as well. They might do well initially, and then we kind of discharge them, and that's fine, but they come back, they're worse afterwards.
Yeah, I mean, I think any tendon transfer, the hardest part is trying to figure out the tension. And really, the only place that I've seen a big change in it is in the hand. So now with wide awake hand surgery, then you let the patient tell you what the tension is.
Oh,
So, I mean, how applicable that would be to shoulder surgery, I'm not so sure, because I don't think you're going to do a wake-up test in the middle of the surgery or anything crazy like that to try to figure out the tension. But the fellows will tell you the technical aspect of doing like an LRTI is easy, but setting the tension on that tendon is the learning curve of the operation, and it takes you a while to figure out like what you're comfortable with and what patients will do well with.
right.
So I think the shoulder's the same with all of these tendon transfers.
Do you guys have any tools in the hand? So other than this wake-up thing, I don't think that's going to go over very well.
No, I don't think you can do wide awake shoulder surgery, at least for something like this. But no, there's no real guides or anything that we use, so it's just experience. But that's a hard thing to teach people.
Well, yeah. So this is the interesting part. So most of the talks now, Burkhardt has been a huge proponent of SCRs. Many other people have been proponents of SCRs. You hear this all over the place. They're working on a billing code for it, and you're finding out more and more problems with it. And we're doing a study on it right now. So again, all these things, I don't think anything out there is a holy grail of anything at the moment. Healing is the biggest thing, and we're finding that the indications, getting narrower and narrower. Where do you think something like this would go?
I mean, I think the most difficult thing that I still encounter in my practice is what do you do with this young, active individual with a massive cuff tear? Like, I still don't think we have the ideal answer. We've tried all kinds of different things. I was a big fan of the lat dorsi transfer when I started practice, and then I just found my patients weren't doing all that well with it, and maybe I wasn't doing a good job doing that operation, but but then I got away from it. I don't know if this is the answer. It's sort of a variation on the theme. But I still don't think we have the answer, and that's why we keep seeing things getting reinvented. I'm not sure where the in-space or the balloon is going to fit into this. I still don't understand how a dissolvable structure is going to, be the answer or the solution. But I don't think. Even now we're seeing, at least in the European literature now, they're starting to put the graft on the undersurface of the acromion and doing the BA bar or whatever they call it, which is just a spacer to try to depress the humeral head, because we've seen the failures with the SCRs at the insertion sites. So now we're trying to get away from inserting it on the humeral head and putting it underneath the acromion. So I still don't think we have an ideal solution.
I think one of the questions that always comes up, at least at the sports meetings, especially with the open surgeons too, where does reverse fit in, and when do you start considering something like that? Because I'll tell you, sometimes in the American meetings, I get a little worried because they go, yeah, why even bother with any of this? It's 30 years old, we'll just put a reverse in.
Yeah, it's an alarming to me. Like, in the last 5 years when I go to the US meetings now, I would say in Canada we're very conservative as to who we put reverse shoulders in because we know how difficult they are to revise, and we also know that they're not without their own complications and their own learning curve. So, when I go to these meetings now, we have entire sessions sometimes now on what to do with a failed reverse. And it's always in people like this where they put it in a 45 or 50-year-old and they're trying to play football or return to work as an EMT. Well, that's not what those things are designed to do or allow you to do. So in my practice, at least, ideally, I don't want to do a reverse in someone under the age of 65. We do them, in that 60-year-old, especially if they have pseudoparalysis. That's a different sort of kettle of fish because you're restoring their function. But if they have sort of more than 60 degrees of forward elevation, I'm very reluctant to do reverse in someone under, 65 or 70 years old because they're not happy.
So that's great. So we have a number. So age-wise, at least in Nova Scotia, we'll say 65 or somebody. But what do you mean by a function? Do you get external rotation back with a reverse?
Not really.
So you get forward flexion?
Forward flexion and abduction, basically.
To 90?
Depends on the patient. You can get higher than that if you tension it right. And again, that's where the learning curve sort of comes into it. But you're not going to restore normal function. You're going to give them forward elevation and abduction. And most of the patients that we do them on have some degree of pseudoparalysis, so they're happy because they're going from 60 to 90 and they can get to their head again or their mouth or whatever. But if you're doing it in someone like this who has a good functioning deltoid, and we've all seen those patients that have no cuff on MRI and they're able to do this, that's the wrong person to reverse in, right? Just for pain, because they're not going to do well from a functional perspective.
So just, again, for a learning perspective, because I don't do reverse, so how strong do you get at 90 forward flexion and abduction?
What do you guys think? I'll ask our fellows because they're examining all these patients post-op.
Yeah.
So, when you test them in the clinic, are they ready to be Arnold Schwarzenegger? Or are they?
No, I don't know. Most of them can achieve at least, at most 4 or 5 degrees of strength in the muscle. But
What's 4 or 5 degrees?
Grade 4 out of 5.
Grade 4 out of, sorry. Okay. Unfortunately, grade 4 out of 5 for me is the biggest range, and this is why when physiotherapists tell me, they're 4 out of 5. 4 out of 5 means anything more than gravity but less than normal.
Yeah.
Yes, you're exactly right.
Exactly that.
So I refuse. I don't accept that from physio. So that's why they got to get a dynamometer before I accept a report from them. Okay. So, but do you guys have a number, or have you, is it 20 pounds, 30 pounds, 5 pounds?
We don't really restrict them from a weight perspective, but I would guess most of them, probably 20, 25 pounds would be the most they could do.
Okay.
That's an interesting thing to think about. I've never really sort of put them on a weight machine or anything.
Well, anyway, just because that's the only way I've been trying to be able to compare at least apples to apples for a patient, right? Because you guys know in the clinic, I'm quite adamant to figure out how strong are they, and it's 4 out of 5 to me, or 4 plus out of 5, 3 minus out of 5. Like, my number is way different from yours and yours and yours, like all the way across. And my today is different from if I have a bad day next day, right? So that's why the numbers, and at least in my head, when we look at our physio numbers, I get somebody else to measure it, not me. I can kind of compare, and I know that, look, if they're getting over 25, I think they're actually going to do quite well. I'm pretty comfortable and not have night pain, be able to manage something like that. And so we're starting to get at least a threshold of what we want. But I'm just trying to get an idea of what I can expect when they're going for a reverse, and when we should actually say, look, we stop trying what we're trying, and you gotta live with it until
What would you let a
65.
60-year-old do with the reverse?
I mean, they can do normal day-to-day activities. They can play golf. Probably not as well as Dr. Urquhart, but they can try to play golf. I wouldn't let them play like any sort of contact sports or do any sort of repetitive, strenuous overhead stuff. They can do all the cardio, that kind of thing that they want, but they're not going back to. I wouldn't let them go back to full unrestricted activities for sure.
Would you let them swim?
Yeah, I have patients that swim. I have patients that ski. I don't like that they ski. It makes me nervous, but I would say, the patients are always pushing the limits as to what they can or can't
Sorry.
do. But ideally, I don't let them do stuff like that.
Yeah. Sorry, or is it mode?
No, it's
I can continue with the paper, or
Yeah. Why don't you continue? Yeah.
okay. So this is a paper. So the one I presented before, it was with the open results, and this is the results with the arthroscopic assisted technique, that one that we performed. So it was published in the Journal of Shoulder and Elbow Surgery. This is the impact factor of this journal. We can see it's not the best, but it's not terrible. It's a very decent journal. So the authors, I don't think they need much of an introduction. So they are very known in the medical field. So Dr. El Hassam has a lot of knowledge in this area. So he began to do a lot of surgeries with brachial palsy patients, and then it led to rotator cuff injuries. Dr. Sanchez Sotelo, both of them were at the Mayo Clinic now. Basamit's at Boston, and Dr. Wagner at Atlanta. So in the rationale of the paper, they talk about massive rotator cuff tears, that they tend to progress over the years to a rotator cuff arthropathy. The rotator cuff repairs, they have high incidence of failure. It's reported in even over 80s and 90s in some papers, even though they're well indicated. That's not always the case, but they tend to fail in some situations. Also, the difference between the transfer of the lower trap and the lat dorsi. So the lat dorsi activates with internal rotation, not external rotation, but lower trap does with external rotation. So it's an in-phase muscle with the infraspinatus. So same line of pull as you see in the diagram. They also speak about the difference of the open surgery, that it worked, but it had some complications because they performed an acromion osteoplasty that was very current. But well, they published their results with good outcomes with open surgery. So the hypothesis for this arthroscopically assisted lower trap transfer is that they would have a reliable pain relief and improvement in function with low risk of infection and deltoid complications. So it was a retrospective case series. The inclusion criteria was all of their patients that underwent an arthroscopic assisted lower trap transfer. The indication for surgery was pain and limitation of activities of the daily life. They also need to have an irreparable rotator cuff tear with two tendons, supra and infra, both of them with retraction to the level of the glenoid, a tendon length of less than 10 millimeters, and a good old ear infiltration more than 2. And also they needed a functioning lower trap. So their population, they obtained 41 patients. It's interesting to mention there was a very young patient, it's 37. That's very advanced to have this type of tears in a 37-year-old patient. But well, the mean range was 52 years old. 66% of the patients were revisions. Also, over 60% of the population had something made to the subscap, either repair of the 2/3 of the top third of the subscap. This didn't affect the outcomes, but it was important to mention. Also, they have improvement in both flexion and abduction, as well as external rotation. All of the changes were significant. Also, in the patient-reported outcomes, all of them, the subjective shoulder value, the DASH index, as well as the visual analog scale, 90% of the patients show a significant improvement in those. And well, they concluded also that the patients with a Hamada classification of 2 or 3, 50% of those were revised to a reverse shoulder arthroplasty. In all of the patients, they showed an improvement, or the distance was preserved on their acromiofemoral distance, and 90% of the population had pain relief. The patients related with negative clinical outcomes, which was like 10% of the population, were those with pseudoparalysis. They defined it as more than 6 months, with a limitation of the flexion of abduction of less than 60 degrees, an arthropathy greater than a Hamada 3, and more than 2 years with symptoms before surgery. This is the complication, so 2 graft ruptures. One superficial infection, 3 seromas. Of the graft ruptures, 1 was revised with a new lower trap transfer, and the other patient didn't want new surgery. They concluded that this technique showed improved in pain and function for posterior superior rotator cuff tear. So now our patients can do external rotation and take the food to their mouth. So strengths of this paper, it's an experienced surgeon, a decent size sample, an innovative and promising technique, which need longer follow-up. Let's see like the true results. It's technically feasible. It's technically different to other techniques like an SCR or bridging reconstruction. So what's going to show us how technically demanding a bridging reconstruction is. It's very different to this. We only use 2 knotless anchors. Limitations, so it's a retrospective case series. The follow-up is very limited. It's just over a year, and the mean measurements. It was just 1 surgeon, so it's difficult to generalize the results. And there's no strength measurements. They mention it in some part of the article, but they don't show those results, and they don't use the dynamometer. It's just a subjective value. And that's it. So thank you so much.
Thanks, Jose. I think we have 1 question online.
Yep.
Just trying to bring that up. Okay. So Brendan Sheehan's asking us which scenario. Oh, sorry, I'm supposed to be closer here. Which scenario would you consider using lower trap versus lat dorsi, or will lower trap replace lat dorsi as an option over time? Do you think?
So I think both of them are very good options. Both of them have shown very good results, both in the open and an arthroscopic setting. But I think the lower trap has the advantage of being in phase with the infraspinatus. So the recovery of the patients is a little bit easier, even though the rehabilitation protocol for these patients it's very tough. So they have to be in the sling for at least 8 weeks. You have to limit the internal rotation to 0, not before. Well, they can go internally rotated not before 12 weeks. But well, the retraining of the lat dorsi, it's a tough part. So, because I just mentioned that the lat dorsi activates on internal rotation, not external rotation. That lower trap does that. So I think that's one of the main strengths of this transfer over lat dorsi.
Great. Thanks.
Thanks, Jose, for doing a great talk after having to pick yourself off the hard, cold tundra after last night's devastating loss. All right. Had to get that in there.
Yeah.
You don't beat Mexico very often, so. Yeah. So next up is Dr. Maud Jeanne Bourguignon. She was born in Montreal, Quebec. She completed medical school and residency training at the University de Sherbrooke, Quebec. Maud is passionate about sports and is happy about having the opportunity to pursue a career in sports medicine. Take it away.
Hi, so my talk is about bridging allograft reconstruction is superior to maximal repair for the treatment of chronic massive cuff tear. It was published this year in the American Journal of Sports Med, and it's a study by Dr. Wong and his team. So it's a standard presentation. So as we know, large to massive rotator cuff tear tend to re-tear after repair in up to 90% of cases. And the reasons for this are that the patients are older, they have poor healing potential, there's high tension on repair, and it's a difficult surgery with a lot of retraction and atrophy. There are multiple options for the management of massive cuff tear. However, for most of them, the evidence are quite limited. So the theory behind bridging reconstruction is that it increases the load to failure and the pull-out strength. So it was compared to maximal or partial rotator cuff repair in a first randomized control trial. It was done here in Halifax between 2014 and 2017, and it's a single center, single surgeon, blinded observer study. So in order to get their sample size, they decided on a 15-point difference in the work score at 2 years, and they ended up with 30 patients, so they randomized 15 per group. And over the period of the study, they collected multiple data. So the inclusion criteria was a massive cuff tear and MRI, and there were a couple of exclusion criteria, as you can see. So on the day of the surgery, the patient had a diagnostic arthroscopy. They were then deemed eligible or not for the study, and then they were either randomized to rotator cuff repair using a single row technique or a reconstruction with dermal allograft using the graft jacket. Then after the surgery, they were in a sling for 6 to 8 weeks. Then they started passive range of motion at 6 and active at 10. So here's the technique. So on the left, you can see the stick sutures and the graft using a code, color code. I'm just gonna start the video. And the size of the graft is according to the size of the rotator cuff tear. So first you'll see the diagnostic arthroscopy and the measurement of the cuff tear. Then the remnants of the cuff were mobilized to see how far they could move. Then the greater tuberosity was prepared, and 2 anchors were inserted to perform a maximal or partial repair, as you can see here. Then progressively, the suture from the graft were passed into the cuff remnants from anterior to posterior using 3 different portals to manage the sutures. And it's really important that the next suture is posterior to the last in order to avoid tangling. And finally, the graft was passed through the lateral portal. We'll see it soon. And progressively, the sutures were all tied from in anterior to posterior. And finally, the graft was fixed using a double row technique. So as you can see here, the graft covers all of the defect. So the results, so the patients, the 2 groups of patients were similar except for the sex, for the number of male and female in each groups. There was only 1 patient who did not complete the follow-ups, and most of the patients were followed for more than 3 years. For the multiple outcomes that were collected, first of all, the patient-reported outcomes. So as you can see, there were improvement in both of the groups for both the work and dash score. However, there was significantly more improvement in the bridging group compared to the repair group and with a large effect size. And also, 80% of the patient in the reconstruction group met the minimal clinically important difference for outcome scores for the work score, versus only 40% in the repair group. Then the range of motion and strength, so both groups increased range of motion and strength. There was no significant difference between the 2 groups. For imaging, so all of the images were reviewed by a MSK specialized radiologist who was also blinded to treatment, and the re-tear on MRI was considered as a tear that was larger than on the initial MRI. So there was 87% re-tear in the repair group versus 21% in the reconstruction group. And as you can see in the repair group, way more patients progress in the rotator cuff arthropathy classification, and 3 out of 15 had end-stage osteoarthritis. And for reoperation, so 7 reoperation in the repair group, 4 were converted to bridging, and the other 3 with end-stage OA had a reverse shoulder arthroplasty. And there were 2 revisions for the graft group. So the conclusion of this study is that bridging reconstruction is superior to maximal repair for large to massive cuff. So we're used to evaluating the value and quality of things, so we need to do the same with scientific literature. So I use the criteria that the American Journal of Sports Medicine uses when they review articles. So first of all, the scientific merit. So it's a level 1 study, which is difficult to do with surgical or techniques studies. The data analysis, it's small groups, so it's one of the limitations. However, they were large enough to obtain statistical significance. They also use modifiers such as the effect size to compensate for the smaller groups. There was also a clinical significance since they used the MCID, and there was only one patient that was lost to follow-up. Then for the available data, we had the PROMs, the physical exam, the radiologic outcomes, and the reoperation rate, which give us more of a global perspective on the outcomes of the studies. And also, the Research Square platform made a video out of this article. I think it's available online if you want to watch it completely. So for the level of interest, so if you look up on the American Academy website, there's only limited evidence for that procedure so far. It means that we still need better studies to evaluate the purpose and the need for this procedure. For originality, so it's not only a RCT, there's also a Dr. Wong's production attached to the paper that explained the whole technique. Then for the validity of the results, so it's the fact that it's a single center, single surgeon study is a limitation, and that's what happened with the first superior capsular reconstruction with Miyata, who had excellent results, but no one could really redo the results. So we need to look in the literature if there's similar data is available. So this is a prospective study that compared bridging with repair, and they had 90% healing in the bridging group, and they had 60% repair in the repair group. Sorry. This one was using xenograft, but they had also 90% success confirmed by ultrasound at the last follow-up. This one is again a comparison of bridging to repair. They also had good outcome results and healing rates. And finally, this one is a series of patients. At the final follow-up, they had 76% of the graft that were completely intact, and the other 25% were partially torn, but none of the graft were completely torn. And then the clinical usefulness. So we, as clinicians, we need to find treatments that improve our patient outcome and satisfaction and minimize the number of procedures that they have to undergo. So an article like this is likely to modify or change our practice to improve our patient's care. So my conclusion is a question we already discussed, but what would be, when would you consider all of these options for a massive cuff tear? Merci.
Well, I think you should be commended for such a, this is a difficult study to carry out. And it's good on you for sort of getting this out there to the literature. It's really well done. And there's always going to be difficulties when you're dealing with small groups. HAMDA classification is slightly off. That's just what randomization sort of present to you. But it's a really good sort of attempt to answer a really difficult problem in the literature in a systematic way. So good job.
No, thanks. Well, we have to say I'm lucky. We have a fantastic team. Obviously, we had Kathy Cody. You were part of it when you're coming through for fellowship too. It's been ongoing. This was a 5 or 6 year recruitment for those 30 patients, so it was a long time. And we have a fantastic team here to be able to actually get all this data, because I obviously could not remember to do all the data collection for something like this. Again, quite an enormous task, but definitely a good learning process to do something like this. And I'll tell you, it puts it in a whole new perspective, right? So following people out with MRIs and everyone, realizing how it's read, all the difficulties with reading MRIs, all the difficulties with getting MRIs, but really gets us thinking about what best to do. At least for me, the nicest part going through is trying to understand, because SCR, obviously it has some benefits somewhere. Bridging, I think it has benefits somewhere. Lat dorsi, we just finished hearing, has benefits somewhere, and reverse has benefits somewhere. So what is that going to be? And that's where I think doing this prospective has really helped me is SCR. I'm having difficulty because people are wondering, when they have more than one tendon tear, more than supra tear, they're having difficulty making that heal on the greater tuberosity. I see bridging, we actually do pretty good on infra. We can actually get infra back. In fact, we're we're going to have the next papers out, because now we're not just analyzing the tear of the MRI, we're analyzing the quality of the muscle, the fatty infiltration, the atrophy afterwards. And again, we're working on the data. I don't have all that yet, but it looks like that's preserved. So it looks like infra gets preserved. But when you start losing 3 tendons, they don't work as well anymore. And then when you have infections, so like our patient there, so we're finding out we haven't been checking as closely as our arthroplasty colleagues on failures. We just assumed it was graft failure. But now when we're actually checking to find the infection, we're finding that, and that may actually be the reason we're not good enough to keep these dead tissue from getting infected.
Do you plan on following them further, like this group of patients? Because like a lot of these techniques have good sort of short to medium term results, but that may be all you need, because maybe it is a bridging technique to a reverse, right? If you buy them 5 years, they're 5 years older before you're putting an arthroplasty in them. But I'm curious to know, sort of what happens to these at the 5-year mark or the 10-year mark even.
Yeah. So absolutely. So that's the plan, right? So obviously that takes another REV. That's the next step. We just finished completing this one. I think that is the next plan that we want to get going. But we have one of our residents has just finished publishing. Accepted? Published? Moyad? Published. Well, published. So just published our midterm results of bridging reconstruction in Journal Arthroscopy. Yes. So minimum 5-year follow-up. Which is, I believe, showing just about, don't quote me on the numbers, I forgot, we reviewed it a while ago, so I think it's something around 75% still healing, good functional results. So at least at 5 years out with, again, those are retrospective review. The level of the rate of MRI fall, it's like 60-some percent, that's the best we could do, right? We're actively trying to get MRIs, but you know how difficult it is to get them. So in a retrospective result, that's actually pretty good. This prospective, obviously, we have a better chance of collecting them, that is definitely the plan. And it's actually even more interesting because data coming out, right? So everyone knows, well, why don't we just cut the biceps and let them go? Because people do well for 2 years. We're finding out that's not really the case. 30% of them actually get really bad really fast. I think I referred you a couple of them. Is that they progress faster than we thought. So some do well, no question. Some do horrible. If they're young, I don't know. I don't know what the right answer is. This is not an easy operation.
And the failed repairs, I think when we try to do a less than complete repair, I think that does progress their arrival at a reverse.
Yeah.
In that sometimes I almost wonder if it's better to do nothing and tell them they got to live with it than do an operation on them and then have them get their arthritis in 2 years instead of 10 years or whatever.
No question. I don't know what the right answer is, right? So I do think that if we can get a bridge works. Oh yeah. So this paper is also on revision cases too, right? So we had a significant number of revision cases on here, and they still do as well. But then we've actually looked back on our retrospective study, which has not yet been accepted, but about to, I think. Yes. Our revision cases obviously don't do as well. It's very similar to the regular cuff literature. They don't do as well. They do improve, but don't do as well as often, more failure rates, whatnot. So again, if we can bridge them, I do think that gives them better outcomes. They don't work all the time, but instead of failing at a high rate, we're failing at a much lower rate. And now, as I'm learning about it, as we're actually starting to do this in the OR, we want to get the maximum repair down to a certain size. We're trying to get ATP dimension down to 25 millimeters. Because I think, having a bigger graft is dead tissue, right? It's allograft, dermal graft. Even though it's acellular, you still have to revascularize it to make it work. It does hypertrophy a bit. But if you have too big a graft, that's too much to revascularize. We're actually trying to get the size down, hopefully get maximum repair that way. And maybe it's going to have to build into this tendon transfer thing too for the ones that are just too big. I don't know. I
do, like with that earlier paper, I would stay away from the acromion because one of the big complications, like the biggest advantage I think of doing it arthroscopically assisted is you don't have to do that osteotomy.
Oh yeah.
Because one of the big complications of a reverse, of course, is stress riser,
yes.
Stress fractures the acromion, right? So the least you can muck around with that, like I think all these techniques we always have to keep in the back of our mind that's probably not the patient's last operation.
No,
so you don't want to burn any bridges or make things more difficult for whoever, i.e. me,
Yes.
that you're
Yes.
sending the patient to later, but it'll be interesting to see how this all evolves over time.
Yeah.
And would this lady be old for piacnes? Is that any age group? 7.
46. Yeah. I don't know. Is it old for piacnes, you mean?
Yeah, like
What-
would be something that you would see in younger people.
No, you see them in all our arthroplasty.
It's quite common in
Even-
shoulder arthroplasty. Probably
Yeah.
the most common.
And so do you do like I've heard of benzoyl peroxide treatment if you know you're going to be doing surgery on them? Do you recommend anything like that? No.
I haven't seen anything so far, at least in talking to our ID colleagues. They haven't recommended us doing anything like that. They do at the revision time now. They want us to take at least 8 cultures if we're revising something.
8?
8, because it's difficult for them
That's
to
it.
grow it. So, it's a difficult infection to identify, and it's low grade, and it's there, I think, more than we think.
Yeah. So do you do anything prophylactically for something like that?
No.
No. So we treat it when we know about it at the revision setting.
Yeah. I mean, I try, you do all your standard workup
Yeah.
for a failed arthroplasty before you revise it, like make sure their ESR, CRP, all that stuff is fine. And then I take multiple intra cultures at the time of the revision. But I would say more often than not, it doesn't look infected. It's
Yeah.
not like a hip or a knee where you make the incision and there's a gallon of pus that pours out and you're like, oh, okay, I got to put a spacer in. This is like, oh, perfect, it looked great, it's all infected. And then 3 days later, these guys are saying, oh, those cultures came back and we have to put a PICC line in and, blah, blah, blah. And it's like, oh, good,
Yeah.
great, perfect. I'm going to go throw up now.
And how successful is it afterwards when you have a positive culture, have to treat PICC line?
So I've been lucky, I think, in that I've only had one, as these guys we just experienced, that I've done the revision and then found the infection on the cultures, and I've not had to revise any of them that we've had this 6 week of antibiotics. Like none of them have failed except for this one.
Okay.
That he was good for a year. I'm trying to think how long that was in. A little over a year that we thought we were fine, and then not so much.
So 6 weeks of IV antibiotics, any more after that, like PO after?
No, they usually, it depends on the cultures and how many that were positive. Like I usually leave that up to my ID sort of people, but
Okay. Oh, I think I'm getting the time. So, well, anyway, thank you very much. We can say that for the people online too, if anyone's still there. So thanks for joining us tonight. I hope you enjoyed the second Sports Medicine Journal Club of this year. We look forward to hosting for more of our virtual Sports Medicine Journal Clubs as well as other events. Just like to take a moment to thank everyone who's made this event possible. Obviously, Dr. Trenholm, you and your team for coming to join us. It's nice to have a bridging gap between our upper extremity and our sports medicine team to get together. I don't think we've done that for quite some time. Thanks so much for my colleagues, Dr. Cody and Dr. Urquhart, for being here and making contributions to this evening's discussion. Of course, our fellows Maude and Jose for your wonderful presentations, great discussions. Thanks to Charles Skinner, as always, our AV tech, to be able to make all these broadcasts possible. And obviously our research team, Sarah G., Lauren, and Sarah, for making this night a huge success. So thanks again for tuning in tonight. We hope to see you during our next Sports Medicine Journal Club on February 16, 2022. Good night.